Hi, everyone. My name is Erin Das, and I am the course coordinator for our first course certificate in Introduction to Palliative Care for Humanitarian Healthcare Workers, focusing on the region of East Africa. We are really so glad that you are with us today, and I want to take this time just to review a few housekeeping items. Most of you will have received an email from myself regarding the course, including a handbook with all the information about the program for the next 11 weeks. You will also hopefully have had a chance to join our WhatsApp group where we will be able to communicate throughout the program in a quick and easy way. For the course, each Tuesday at this time, we will be doing a Zoom call. And I do want to remind you for attendance purposes, at the end of the course, if you would like to receive a course certificate of completion, we would ask you at this time to rename yourself on Zoom to the name that you registered yourself on the Google form maybe a few weeks ago when you registered for the program. It's really important that you have the name that you use for registration, as we will be checking attendance, and this is the way we will track and know who to share a certificate with at the end of the course. So now I'll just take a chance to share my screen and we will begin the program. All right, so again, please rename yourself so that we understand. The way that you do this in Zoom is at the bottom of your Zoom screen. You hover over yourself and then you click on the blue or more button and then you select rename and then you enter your name. So if you can do that with the name that you registered in the course, that will help our administrators to ensure that we have tracked you for your attendance. All right, so I just wanted to say a very warm welcome to this program. Today we will be talking about the course in general, and we will have our faculty members just give a brief introduction of what palliative care is and the setting that we are talking about as we introduce palliative care for humanitarian healthcare workers. So again, my name is Erin Das. I am a palliative care nurse from Canada. Currently, I live and work in Nairobi, Kenya. And I'll be helping coordinate this program for the next several weeks. I have a great honor to be working with so many wonderful faculty members. We are 16 members of faculty, and many of them are on this call today. You will also notice many of them are on our WhatsApp chat group. And it probably will be great as we go throughout the course for you to make note of who is working and which regions they're working in. And you are more than welcome to reach out to them through the contact list that I shared in the handbook. So you can either reach out to them via phone or email that was shared in the handbook. It's the last page of the handbook, the PDF that was shared with you all. So these are our faculty members. We have people, faculty from East Africa, including Kenya, Uganda, as well as faculty from the UK, from Australia, from the United States, and Canada. For this program, we will have 11 sessions. We've mentioned that several times. 7 of the sessions are mandatory, and 4 of them are called CMEs. So they are going to be open to a wider audience. If your colleagues didn't get a chance to register for the course, and now that you've enrolled in the course, you've been talking to them, you are more than welcome to invite them to the CME courses. They will be open for all participants. Each week, we will ask you to watch a video before the class. I shared that earlier. Some of the videos are around 20 to 30 minutes, and some are a full hour, which are recordings that we would encourage you to watch based on the topic of each week. The summary teaching sessions and in this course, we will be doing a summary of the topic during our live classes, and then we'll move on to the clinical case presentations. And if you were able to be present or in attendance for all of the 7 mandatory sessions, we will be able to grant you a certificate for the program. So this is an example of what our classes will look like. We will do a short introduction and welcome by the facilitator at 4 o'clock. We ask that each of you try to come right at 4 o'clock for the program, but we are recording the session, so you could watch if you show up a little bit late. We then will move on to a summary of the teaching topics. So each of the 11 weeks, we will have new topics to share. We then will move on to a live discussion time where you can put your questions in the chat box, as well as we would invite you to unmute yourself or raise your hand, and the facilitator will call on you to unmute yourself to share your perspective on the topic or ask a question. After that time of discussion, we'll move on to a case presentation in which one of our faculties will present a case which has occurred in a humanitarian setting, and we will learn from these situations. We will then end the program with a final discussion on the case or the topic that we have talked about, and we will have a time of summary and announcements. So in terms of Zoom etiquette, I know because of COVID-19, we've all had a chance to learn about Zoom and learn new skills to attend classes virtually, but I want you to try at your most to keep your video on, if it is possible, based on the bandwidth and what you have access to. We would like to make sure that you position your camera so that you can be seen. We do ask for all the participants to keep muted and avoid background noise, because we have quite a few participants enrolled in this program, and it is very important that we avoid this background noise. Again, we've talked about ensuring that you have labeled yourself correctly when joining the meeting. So please make sure it's your name and not, for example, iPad or Samsung Galaxy. We would ask and encourage you to write your questions or comments in the chat box. We have several of our faculty members that are monitoring the chat, so they will be able to respond to you while we're going through. And when the facilitator calls on you to speak, that is when we would ask you to unmute. So in terms of our schedule, we have shared this with you, but the program is as follows. Today is May 17th, and we have the introduction to palliative care and an introduction to the course. On the 24th of May, we will do an overview of palliative care, and this will include different conditions, including limited resource humanitarian settings. On May 31st, our third session, this is the open session or a CME, in which we will talk about providing palliative care to children in vulnerable settings. On June 7th, we will talk about opioids and pain management. June 14th, about symptom management, and June 21st, about communication techniques in palliative care. We will then go on to June 28th, where we will talk about supporting patients with psychological distress, including a trauma-informed approach. And this is an open session CME session. On July 5th, we will also do another CME session in which we will learn how to break bad news to patients and families. July 12th, we will talk about spirituality and palliative care, including grief and loss, support to patients and families. On July 19th, we will have end-of-life care and nursing issues, and we will end the course with an open session on July 26th, talking about how to support healthcare teams related to palliative care cases, and debriefing, including self-care and supporting one another. In terms of evaluation of this program, we did send out an email earlier today in which we've asked you to fill out a short online survey at the start of this program. This is a different survey than the registration, and it is a voluntary survey for some research that we are trying to collect. We will also ask you to do a follow-up survey if you are interested at the end of this course. Each week we will grant you access to a Google Drive in which we will be posting the weekly presentations that are shared. And I will share the links on this presentation to all of the participants. So if you wanted to follow up with the presentations and review the information, you will find it on this Google Drive link. We also want you to have enough resources to learn about palliative care. So we have another Google Drive link in which there are PDF versions of more resources and information, including textbooks, in which you can read at your own time. We do have a YouTube link in which we have the pre-recorded videos. At the moment, there are 12 videos that focus on palliative care teaching for humanitarian healthcare situations. So we would encourage you to view these videos as well. We will be sharing these videos each week, but if you did want to take a look at the full playlist, you are able to do that. Our WhatsApp group is live and active. You can join via this link to our chat, and all of the materials for the program will be posted on this group as well. So that's most about the administrative aspects of this course. We are really looking forward to a really positive program for the next 11 weeks, and we thank you so much for enrolling in this course. I now will pass on the program to Dr. Megan Doherty, who will talk a little bit more about the ECHO way of teaching and the ECHO program.
Thank you, Erin, for that message, and a very warm welcome to all of you. So I'll just mention a little bit about the idea of ECHO, because you'll notice this is an ECHO course. I'm going to turn off my video because I think my connection is not so strong. Just go to the next slide, please. So basically, we're calling this a Project ECHO because we're using a certain teaching format. And this is the idea of what Project ECHO is. It's used around the world for many different teaching of different types of doctors and healthcare providers in many different settings. But you'll see in the middle, the people who are in black are called the Tele ECHO Hub, or the expert team. And that includes all the faculty that Erin showed you earlier in the slide. And so then you have yourselves, which in ECHO language are called the spokes, or we call the participants, and you're shown in this diagram in red. And so some of the knowledge that we share with you, you see the arrows, it goes to you guys, and then you as participants would use that to help your patients or share with your colleagues, or inform the practice that you have, your medical or your nursing or your healthcare practice. I like this diagram, but I think it should have more arrows. I think there's also in ECHO, we know there's learning that happens between the participants. So between the different folks in red, you share with each other and you learn from each other. I would also say that you share and the faculty learn. So there's bi-directional learning going both ways, going back up as well. And we all learn from our patients. Next slide, please. You'll see the Two Worlds Cancer Collaboration logo on all of the slides and documents for this course, and that's because Two Worlds has a big presence in creating ECHO programs around the world. And one recent one that I want to highlight is that we've been doing a ECHO response on palliative care for Rohingya refugee healthcare providers in Bangladesh and in South Asia, and that course has run 4 batches already and is on to the 5th one. And there's some other ECHO courses listed there. Someone is not muted who's getting the call to prayer, so please do mute yourself.
Sorry, Megan.
No problem. And then there's a partnership as well. In Bangladesh, we had the Fascinating Khan Research Foundation who helped us because they were main healthcare provider for the Rohingya response. And in this course, of course, it's CAPTCHA. And then PalChase, which is, I want to highlight PalChase. It's a network of professionals focused on advocating for palliative and end-of-life care needs for people affected by humanitarian disasters. And so I would say that you are very welcome to join PalChase. PalChase is about connecting with others who are doing the similar work to what you're doing, who are interested in palliative care, who work with refugees or work in humanitarian settings. and you can go to the PalChase website and there's a button there to join. It's free to join, but it's a way to connect with other people who are facing similar healthcare situation to yourself. Next slide, please. And I just want to emphasize that ECHO is not telemedicine. So when you learn things in the ECHO, it's in a little bit more in general, and you take that information and then you're going to reach your patients and make decisions about how they should get the best care. We're not seeing the patients directly on the ECHO, and we can't take the responsibility for the care you provide for your patients. Next slide. And the most important thing to remember from ECHO is all teach, all learn. This is the slogan or the motto of ECHO. And the idea is that starting from today for the next 11 weeks, we create a supportive community where we all learn and share together. So questions are encouraged. We have, as you can see from what Erin shared, a lot of time for discussion. And this is very important because the discussion allows us to learn better. If you just come and you sit and you listen, you will only learn a little bit. You have to engage in the topic. You have to think about, how would I change my practice? How would I do this for my patient? And that's why there's lots of cases and lots of time for discussion. So I encourage you to discuss, to ask questions, to write in the chat. Next slide.
Thank you, Dr. Megan. I think that's the end of the presentation. So thank you so much. We will now move on to our teaching part of the program. Again, just a reminder, keep on mute for all the participants, and we will have a time of discussion after the presentations occur. There are a few people that I would like to introduce that are on the call today that are not going to be speaking, but are very important to this program and who have been great partners in facilitating this session. And first of all, of course, Dr. Megan Doherty, thank you so much for helping inspire us to start a program here in East Africa and allowing to support the work that's ongoing here. I would like to take the time at the moment, Vicky, I just wanted to introduce a few other partners before you share your program. Is that all right?
My name is, hello.
Hey, Vicky, I'm just going to introduce a few of the partners that are on the call today. Is that all right?
Oh, it's fine.
Okay. So if you just stop sharing, I'll just introduce them and they can say a welcome, and then I'll introduce you when it's your turn. Thank you. So again, Dr. Megan, thank you so much. Our next person I wanted to introduce, and maybe you can just say hello, is Makulin Ateno. She is the Executive Director from KEPCA. Makulin, would you like to say hello to the crowd? Or the participants, I guess. We're kind of a crowd today.
Yes, thank you so much, Erin, for the opportunity, and thank you so much, our participants. We are really happy to have you. I'm Makulin Ateno, as Erin mentioned, and the Executive Director of Kenya Hospices and Palliative Care Association. KEPCA is the umbrella body which supports palliative care advancement and development in Kenya. We are happy to be partner and be part of this session because, as you all know, palliative care should reach everyone regardless of who they are, where they are, and the conditions that they have, as long as they have palliative care needs. So having this this certificate for palliative care in humanitarian settings people is very important, because we know that people who have humanitarian needs also have a lot of palliative care needs and many of the rights which are affected. So we are really happy to be part of this and join and learn more from each other. And hopefully by the end of this certificate, we can use the skills and the lessons learned to improve the care for people with palliative care needs in humanitarian settings. So thank you and welcome all. Back to you, Erin.
Thanks, Makulin. It's great to have you here. The second person I'd like to introduce is Dr. Stephen Kinara from IRC. He currently has been a great partner with us here in Kenya, and we're very happy for you to be here. Dr. Kinara, are you able to say a quick hello to all the participants, especially your colleagues at IRC?
Yes, I am. Thank you, Erin. I think we've all been waiting for this moment, I can say. And I'm sure my team looks forward to learning quite a lot and using that in the humanitarian setting to improve quality of care. Thank you.
Thanks for being with us today. We do have a few other representatives from KEPCA, and I'm hoping that you will be able to introduce yourself on the chat. I think I saw David is with us today. I'm not sure if Dr. Esther Munyinga is also with us today. But we are the National Association here in Kenya, and we also have representation from Palchase, which is great. I would now like to move on to the lecture or the teaching part of the program. And I would like to introduce Dr. Esther Nafula. She's a consultant at Kenyatta National Hospital, and she will begin the session today to introduce palliative care and what palliative care is about.
Thank you. Good afternoon, everyone. I hope you can hear me well. I'm going to start sharing my screen now.
Dr. Nafula, I think we lost you.
WHO's definition is quite close to that by defining palliative care as an approach that seeks to improve the quality of life of patients facing problems that are associated with life-threatening illnesses through prevention by means of early identification, impeccable assessment and treatment of pain, other problems, physical, psychosocial, and spiritual. So the focus of the definition of palliative care is that our aim is to improve the quality of life, and not just for the patient, but the patient and their family as they go through a life-limiting or a life-threatening illness. And it is through holistic care by not only handling their physical problems, but their psychological, social, and spiritual problems as well. Palliative care is a very essential part of healthcare because it focuses on relieving and preventing suffering for patients who have an incurable disease. So many of the patients we encounter, we might not be able to cure them, but we can be able to give them good health and well-being, and part of our biggest goal is to communicate with the patient and their relatives about their diagnosis, their prognosis, their treatment plans, and to help them to make good decisions about their care. So why do we need palliative care in humanitarian crisis? So there's extensive loss of life, there's extensive loss of health, there's a lot of physical, psychological, social, and spiritual suffering that is associated with the population that need humanitarian care. And sometimes even where cure is possible, the patients are not able to access care. When we think about our refugees in Kenya, for example, in our biggest camps in Dadaab and Kakuma, the patients are not able to access curative interventions. And even when they are referred, for example, to our national hospital where I work, there's a lot of financial constraints and there's a lot of delays in their care. Many of the individuals who are frail or older, or babies who are born prematurely, or those who have any other diagnosis of a life-limiting illness and need a lot of care, there's barely any budget for it or any attention paid to these patients. Now, palliative care is not about cure, but it's about living well. When we are not able to cure our patients, we still should be able to provide them care for them to live with their disease. So many people think that palliative care is only for patients who are about to die, those who have a week or days to live, but palliative care can be provided for months or years. The aim is not to hasten death, but to improve the quality of life for patients and their families as they go through the problems that are associated with life-threatening illnesses. So some of the things that we do in palliative care for our families and patients, and is what we'll go through this ECHO program, is first of all, pain assessment and management of distressing symptoms such as nausea, vomiting, anorexia, dyspnea. There is advanced care planning, which involves having discussions with patients and their families about the kind of care they would want to receive in case of deterioration, poor health, or in case they are not in mental capacity to make decisions. We also do end-of-life care, spiritual, emotional support, and psychosocial support. And this psychosocial support includes also transitioning the patients from hospital setup to community setup after they've gone through treatment. So some of the barriers to palliative care, especially in humanitarian situations, of course, the biggest problem is funding and availability of resources, and resources includes human resource, pain and essential medications. There are no guidelines of how to take care of patients in the setup. There's security challenges, even accessing the area sometimes is hard. There's host community relations. Some of our patients will be coming from war-torn areas, they're refugees, they've come into our countries. There's no clear guideline of how they should be handled. There's issues of continuity of care. When we are discharging a patient from hospital back to a refugee camp, what kind of resources are available to take care of the patient? What kind of support is there? There's really a big gap when it comes to continuity of care. There's also issues of culture. There's various cultures and how we consider issues of illness, issues of health-seeking behavior, issues of death, and even the terminology to use when we are dealing with our patients. Then we have ethos or ethical issues that arise when we are handling patients in these setups. Now, I want to encourage us as we go through this ECHO program to know that no matter the challenges, the inadequacy of resources, inadequacy of funds, that apart from just trying to save lives, we can also relieve the suffering of our patients and our communities, so we can be able to offer both curative interventions and palliative care. So where we are not able to cure, we should still be able to give care that will improve the quality of life of our patients and their families. So palliative care is about giving person-centered care. Palliative care is everybody's business and it starts with you. So there's something we are able to offer our patients at any particular time, and we should be able to identify that and to be able to give the relevant care. So in summary, palliative care is holistic. It is about the patient and their family. It is very patient-centered. We look at the needs of the patient and try to meet those needs. It is for any patient with a life-threatening or life-limiting illness, for all age groups, and it can be given alongside other therapies, whether it is curative therapy, rehabilitative therapy. They can go alongside palliative care, and our biggest aim is to help the patients and families have quality of life and optimized function. Thank you.
Thank you so much, Dr. Esther. It's great to hear the overview from you. And Dr. Esther is based in Nairobi, Kenya, and she's going to be one of our main faculties for the duration of this course. She is a wealth of knowledge, and she's actively working to support Kenyans here in Nairobi. So if you, again, please do reach out as necessary to our faculty members. We are here to support you. Although we are virtual, we are here to support you. I'd like to take the chance now to introduce our next speaker. Her name is Dr. Zippy Ali. She will talk now and continue the discussion about palliative care in humanitarian settings. Many people who live in Kenya know Dr. Ali well, and I'm really proud to be able to call her my friend and also colleague. So welcome, Dr. Ali, and please share.
Thank you very much. I'll just Thank you very much, Erin. I'll just put my video on briefly so that it doesn't interfere with my presentation. So good afternoon, good evening, good morning, everyone. I notice people are from all over, and that's great, from Africa, from other parts of the world. And that's really just goes to show us we are a global village, that we all have needs that we can actually address collectively and look at how we can support, especially those very vulnerable populations that we have with us, but maybe we don't do the best for them. So we'll just have a few slides to talk about palliative care in humanitarian situations. Thank you very much, Dr. Nafula. That was a very good introduction. I think you've actually touched some of the things I was going to talk about, so I'll try to be brief. And so now that we understand what palliative care is, I think the next thing is for us to look at, is it important for us to have palliative care in our setups, especially in humanitarian situations? Why is it important? I think it's important because first and foremost, people living in those situations are just people like us, like you and me. They are people, they are human beings, they deserve a better life, and they deserve to be able to receive quality care from prevention, promotive health, curative, rehabilitative, reproductive, palliative, and mental health. And we know that's actually what is required of every country, that everybody should actually access quality healthcare services. So if you look at, if you try to read about human rights and health and human rights and palliative care, there are many things that you will actually find on the internet, many treaties, many conventions that talk about humanitarian situations and the right to palliative care, the right to health. And so it's important that as we go through this, I don't know how many weeks it was, that by the end of this session, we'll understand that every person on this planet, literally every person, whether they're refugees or not, irrespective of their race, color, gender, religion, whatever, is actually, it's important for that person to access services when they need them. And of course, services that do not put them into poverty because of the money they're spending. So it is a human right actually to be able to also access palliative care services when you're living in these humanitarian situations. It does not mean that because you live in Dadaab and the refugee come in Dadaab or Kakuma, you should not be able to receive these services. So remember that it is important of the human rights policy that people should actually access services. So we know that there are many people who need palliative care. If I will put the links to this books on the chart later on. If you look at the Global Atlas of Palliative Care, it talks about over 40 million people need palliative care in the world. 75, 78, or close to 80% of these are from low and middle income countries. That is countries like Kenya and other countries that are represented on this in this session right now. So many people need palliative care, but only a tiny bit of them really access palliative care in our countries. Most of the palliative care is found either in the US or part of Europe or Australia, but not really necessarily in Africa and Asia and Far East Asia. So again, only a very few percentage of our patients are able to access palliative care services. And also later on, we look at issues of access to essential medications for palliative care. For example, oral morphine for pain management is not well distributed. We find that 80% of the morphine, or not necessarily oral, but of the opioids we need for managing pain are also found in those countries that are developed, whereas we know 80% or 90% of the patients in need live in Africa, Asia, and other developing countries. There is a big need for palliative care, for us to integrate palliative care across healthcare systems at all levels of care, irrespective of which part of the country you're working. And just last week, I was visiting rural Kenya. I went to Vihiga County and within Vihiga County, we visited about 6-7 sub-counties, looking at how we can actually improve access to care for NCDs that also includes palliative care. So we need to remember that people in these kind of situations are also people we need to reach out. So who can provide palliative care? Dr. Nafula talked about what palliative care is. She said it's about physical, emotional, psychosocial, and spiritual needs of our patients. So people working in this domain, healthcare professionals, can provide palliative care. It doesn't necessarily have to be a doctor, nurse. They're very important, they're very key. In fact, they take up the leadership, but also people like community health volunteers, the community itself, the family members itself. In fact, we talk about compassionate communities, where we actually also the community can take care of the person who is sick within their communities. So you might maybe be having specialist palliative care where you're working, or general palliative care practitioners, but again, it's very it's not really common to have specialists in most of our parts of the countries of Africa. So we actually now need to look at how can we integrate palliative care into our nursing, clinical officers, undergraduate medical students, anybody working in the healthcare services. How can we train them so at the end of their diploma or their degree, they actually at least have the essential concepts and skills and knowledge to be able to provide palliative care at the level where they'll be working. So everybody, actually, every healthcare provider and elite healthcare provider should have the principles, the basic principles of palliative care to be able to provide it appropriately. So that is just to make sure that we don't think every place might have a specialist. Not everybody has a specialist. So palliative care in Africa, I will not go into the history. There's a book here that has got summarized how palliative care started in Africa in the late 70s, with the Zimbabwe being the first place to have a hospice, going to South Africa. Then Kenya was in 1990, and then Uganda, Botswana, many other countries followed up, and it's still continuing. This is not the exhausted list, but we've seen a lot of improvement in terms of palliative care in Africa. There's a lot of interest, there's a lot of goodwill from our governments, the public, the healthcare providers, but we don't have enough funds and we don't have enough human resource to be able to manage, to be able to actually make sure that palliative care is fully integrated into our healthcare system. So we need to work on that as well. Even though we have these services, we do not have enough human resources. So I was looking at one of the websites that deals with humanitarian situations, and I'll send you the link as well. They talk about challenges in palliative care, and Dr. Nafula talked about this as well. She talked about the fact that maybe people who work in refugee camps focus mainly on life-saving and forget that those who already are sick or need to be supported throughout their illness, and we forget those ones and focus mainly on how can we save life. Both are very important. Dignity is very important. Alleviating suffering is very important. Prolonging life, if it's possible, positively is very important. So we need to focus on also supporting those who are already sick and have all these needs that we need to address. So we cannot save everybody, but we can reach everybody and relieve their suffering and bring dignity into their life. So these are important things that we need to understand. So of course, the most important thing is healthcare professionals need to accept and adapt palliative care as one of the services they need to provide for their patients, and things like the use of morphine is very difficult to control. So just going to summarize this paper, I'll share with you. I've actually put the link here, but I'll share it on the chat. It talks about the ethos of humanitarian action. It talks about the need to optimize resources in humanitarian settings, the need to appeal to donors, lack of training and expertise in this area, barriers to accessing pain medications, concerns that this care should be provided by local actors. This is very interesting because it says sometimes people from a different culture try to talk to a completely different culture and they don't take it very well. So using local resources is also very important. And of course, having policies and other things, and security risks in some of the places we work, the terminology we use, acceptable culturally, all these things are very important. Like I said, I will share this for you to look at this. So this paper recommends a lot of things. I will not go into them, but it recommends, the recommendations are very useful for us if we want to work in these situations that are very complicated. How can we work within, for example, the Dadaab camp or Kaguma camps? For those who live in Kenya, you'll know what I'm talking about. And I was talking to a nurse this morning who works in the Dadaab. She's one of the trainings I was doing, and she was telling me that I have this patient who has got a tumor on the head. It has gone into, it has spread to the eye. It's all over her body, and there's nothing we can do for this patient in the camp. Unfortunately, as Dr. Nafula said, these patients end up dying when they could actually have access. Maybe some of them actually, the diagnosis is made at a very early stage, but because of where they are, who they are, they have no access to proper treatment. And even if they have access to proper treatment, they have no access to palliative care. So patients die in pain and suffering. Patients die when we know we could actually have, treated them at an early stage, just because they live in camps, they have no country, and so I know this is a discussion that has come up with in Kenya, and one of the things that the Kenya Medical Practitioner and Dentist Board is looking at right now is how can we involve refugees? How can we put them under the National Health Insurance cover, so that if we have a child who has, for example, osteogenic sarcoma, we do not let this child die, but bring them to Nairobi or to Eldoret, where they can access treatment. In 2019, when I was in Dadaab, we did a ward round with the team there, and there was this young child who had osteogenic sarcoma. That's why I'm talking about osteogenic sarcoma. Actually, I thought if that child had accessed treatment, they might have lived. But because they're in a camp, they don't belong to this country, they have no birth certificate, they have no national identification card, they are not able to access treatment. So these are some of the things that we do that are not right. We need to be able to address these issues. So I'm just about to finish, Erin, don't worry. So in Kenya, how have you tried to help people who are in those, how have we tried to reach the people who are in humanitarian situations? I know that in 2019, when I was still with Kenya Hospices and Palliative Care Session, we actually did some training in Dadaab and Kaguma. We trained healthcare workers for about 5 days, and we encouraged them to be able to provide palliative care to their patients. We had done a training actually in 2008, but did not follow up. The challenges that usually happen is that when you train people in these camps, most of them are not there for long. Because of the hardships, they keep on moving. So they have people coming on locums and going away. So the people you train move away, and these people are left with untrained people. So we need to look at how we can motivate incentives that can actually support healthcare workers who have been trained to stay in these camps and be able to support these patients who need these services. So those are some of the things maybe we can even explore during this training. How can we motivate and incentivize healthcare workers to be able to continue working to provide these services? So there are many publications that you can read. The WHO has actually a number of publications for children, for adults living in humanitarian conditions. These publications are free. Please visit the WHO website and download some of these publications, because they can help you understand how you're going to take care of your patients, how you're going to change the way patients are treated in the place that you're working. Reach out to them. And a lot has happened since then, especially during this COVID-19. We've had many webinars, maybe many CMEs on how to deal with situations that are very complicated, how to reach out to patients. When you come across this kind of webinars and continued medical education sessions, please attend them, because you gain a lot of information and you're able to share and also learn from others. This is just the Humanitarian Charter that looks at what should happen in terms of these situations. We talk about health systems, but it talks about focusing on different aspects of care, whether it's non-communicable diseases, communicable diseases, maternal health, mental health. All those things are important because, again, like I said, these things are actually common across. It doesn't matter if you are in a refugee or not in a refugee, we have all the same problems. So again, I just want to end with one slide that shows what has been happening in Africa. These are some of the national institutions in Africa, including the regional session. They can help you if you're from one of these countries: Malawi, South Africa, Uganda, Tanzania. We have also our regional office, African Palliative Care Session, that would be also very, very willing to work with you, to support you to be able to integrate palliative care services where you're working. So don't feel shy or anything. Reach out so that we can actually support you in how we can help you to integrate palliative care services. So sorry that I've rushed through this, but that's all I wanted to share today. I think the most important for me takeaway message here is that somebody in the camp is just as important as I am, wherever I am. So what I want for myself, I should be able to give to the other person as well. And so please take care of your patients, continue. It's difficult, it's not easy. I've visited those camps. I have really empathized what goes on there. I think we can still make change, and we don't have to give up. Thank you.
Thank you so much, Dr. Ali. It's really great to hear from you, and I'm so glad you were able to be with us on our first call today. So thanks again for sharing. And as we've been mentioning, we will be able to make all the presentations available to you online. So that'll be great. We have one final session or lecture for today, and then we actually are going to be breaking out into groups. And we will have interactive session after we hear from nurse Vicky Opia. Vicky is a nurse that currently works in Uganda supporting refugees in her community. And Vicky, I'd like you to take the chance now to share your screen and tell us a little bit more about the work that you are doing in your community with refugees as a nurse promoting palliative care. Welcome, Vicky.
Thank you so much. My name is Opia Vicky. I'm a palliative care nurse practitioner. Adjumani district. Adjumani is one of the districts in Uganda that hosts the largest South Sudanese refugees. And we also have refugees that comes from Congo, and it's where I work. So briefly to share my personal reflection on how I have been offering palliative care in this part of the world. Our community is largely influenced by traditional culture, an effect of northern insurgents of 1989, of refugees in our community, then HIV, poverty and traditional lifestyle. 400,000 refugees that came in Uganda since 2013 to date. We have 80% of our population of the refugee population, 48.8% male and then 51% female. As many of us have said, like Dr. Zipra and Dr. Esther Nafula have just mentioned right now, that palliative care is a human right. That if you don't get it, then you're trying to inflict pain on human beings, inclusive of the refugee. You can see the map of Adjumani. We have around 11 sub-counties, and all the sub-counties host refugees. Therefore, we are covered with refugees in our district. And Uganda, some of these highlighted areas are where some of the refugees from Congo, South Sudan are being hosted. Many times when refugees come in our countries, the first thing we need is shelter. We think about food and then the health care. Palliative care has got a policy that many of us have known, that provision of palliative care is a moral imperative of health system and should be integrated in all levels of health system. And also we are saying that according to the World Health related issues, that access to palliative care is a core component of health system, and we emphasize it as even in community and then home-based care related issues. What is the situation of palliative care like in humanitarian setting? Initially, palliative care was only provided in the district hospital. When I completed my bachelor's, I started palliative care in a district hospital, and a colleague of mine also had a diploma in palliative care. So in a health center, we initiated palliative care. There was inadequate pain relief, that is morphine, in these hospitals, and also essential medications of palliative care that we know, like the dexamethasone, the bisacodyls and other essential medicines were really limited. And palliative care was not prioritized in a humanitarian setting at all. We didn't have any palliative care by then. And also health workers were so very few, inadequately trained in palliative care. Stakeholders were not aware. When you start talking about palliative care, you need to take essential explaining what palliative care is. And the community was not also sensitized at all on palliative care. There were no policy-related issues on palliative care. What did we do then as palliative care practitioners in Adjumani with our partners, with other funders? We had to start engaging ourselves into stakeholders meeting within the district, involving the political leaders, the religious leaders, the cultural leaders. And also we conducted a research to ascertain what is it like, what is the experience of the refugees that live with life-limited illnesses or chronic related issues. And then we went ahead to have dialogue meetings, family dialogue meetings, community dialogue meetings. Then we prioritized radio talk shows that over 24,000 or even 10,000 listeners listen to the radio talk shows within our locality. Then we trained health workers, we trained VHTs, we trained what are called mentors, and we did not forget to train the really caregivers that the last breath will be taken at the hands of these caregivers. So we trained them also. And we conducted CMEs in all facilities, even after these trainings. And we had an opportunity then to do mentorship, support, supervision within the facilities that we've trained to the health workers. Did we make achievements? Yeah, we made very many achievements. One of the things that our funders supported us with is support the village health team with bicycles, so that while in the community, they reach the patients and then link them to the facilities where these health workers have been trained. Then we also distributed them phones. In the forms, they formed a WhatsApp group. Using the WhatsApp group, they are able to identify their own issues, tell stories of the pictures they have taken, and then post pictures, and we're able to diagnose a condition, and we support our healthcare, our VHTs, and then the patients. Those are the number of health workers that we've trained, around 100 VHTs, around 175, and we trained about 400 caregivers. That covers the whole of these settlements. We have around 18 settlements within a Jumani district. And also, as I told you initially, the radio talk shows is being listened by so many people and stakeholders. Over 257 of them had the meetings that they attended to. The health center 4s, health center 3s, now as we talk, some of them can manage simple cases, but then still refer complex cases in the hospital. Now we have availability of morphine, both in the hospital and then in a health center 4. And the district has got what we call a district-led palliative care focal person who sit with the district to plan for issues related to palliative care, voicing the issues of the voiceless, so that it's being heard and it's being budgeted for. We have scaled up palliative care, not only now in Adjumani as a district, but we have moved to the next district as where the refugees are also being hosted, that is Obongi and Moyo districts. You may be thinking that we're not having challenges, but then we're having challenges, that palliative care is still not being prioritized by the government and other non-government agencies. Much as we say now they offer palliative care, but some of the nurses or the clinical officers that have attended training have been given other responsibilities. Therefore, workload becomes a challenge. And even us who have been trained, like some of us are having bachelors, others are having already masters in palliative care, but we're not being recognized anywhere. That means you cannot compete for any position in the district. And also, there are inadequate policies. Even if the policies are there, they are not being enacted. We have issues of culture, we have issues of social barriers, yes, such as belief about death and dying still persist, and then misconception about palliative care, and then also misconception that improving access to opioid analgesics will lead to increased substance abuse is still with our community, that we are still trying to drag out and work out with. Did we learn a lesson? Yeah, we learned a lot of lessons. We are saying the key lessons learned is that when you involve stakeholders, large number of stakeholders, bring the religious, bring the political, bring the culture, then you are able to move and also ensure that different approaches like the radio talk show, maybe dialogue meetings, and then mainstreaming palliative care in other areas will work. You have to involve the community, and then you have to inspire others, involve others. Let the workload not rest on yourself alone. I have learned to work with my colleague nurses in various areas.
Vicky, are you still there? We may have lost Vicky. but I think she was getting closer to the end of her presentation. Okay, so as we just wait to see if Vicky will rejoin us again, I just wanted to again remind each of you throughout this program and throughout the next 11 weeks, don't forget to rename yourself on your Zoom account to your name, your first name and your second name that you used when you registered for the course. There are several participants, which is great to see. We have about 140 participants that have made it on the call today, which is great, but it will just require us a lot of administrative side work to make sure that we have our attendance tracked properly. So just a reminder, please rename yourself. If you have any questions, you're welcome to put them in the chat as we go. We now are going to get ready to go into breakout rooms. I don't know if the other faculty members, does anyone see if Vicky has rejoined us?
I can keep an eye out for that.
Just joining.
Is she joining now? Okay. So once Vicky has finished and completed her teaching session for today, we are actually going to go into breakout rooms. We won't do that on a regular basis for the call. We'll leave most of our discussion for the larger group. But today we want to get to know each and every one of you. So I will invite our faculty members to lead the discussion in the breakout rooms. So I have created about 10 rooms in which the faculty members that are on the call right now can just help facilitate a discussion. We would like each of the participants, if you're able, to unmute and introduce yourself, and then maybe share what you would like to learn from this course as we go forward in the program. So I'm gonna, unless Vicky has rejoined us again.
I don't see her at this time. I've been looking.
No, okay. So I'm just going to name out the faculty members are here. A few people have messaged me that they're not going to be able to facilitate the call, which is okay. So if you're not able to do that, that's all right. But I would like to call on Dr. Megan, Dr. Anna Vork, who is with us today. Dr. Stephen Kinara, I hope that you're able to help us facilitate one of the rooms. And then Dr. Nafula, Dr. Ali, David from KEPCA, as well as Dr. Esther from KEPCA. I have you both in separate rooms. I know Julia Downing just said she wouldn't be able to facilitate a room, so that's okay. And Makulin, I hope you're able to help facilitate a room. I think I already said Dr. Esther from KEPCA. Dr. Ali, if you can help facilitate, and Ruth, the palliative care nurse on our faculty. I'm going to send you all into breakout rooms. I think Vicky must have lost her connection. She was calling us from Uganda, so maybe her connection wasn't so strong. But I'll send you into your breakout rooms. Again, if you can introduce yourself in the room and just say where you're working, and then maybe one thing that you're interested in learning, that would be great. And I see, Dr. Megan, you have your hand up.
Just to say, if you don't have a faculty in your group, then just lead yourselves in your group, just in case there's any groups that don't have faculty. You go ahead and organize as a group of participants.
Yeah, perfect. So there might be a group that may not have a faculty, or they had to drop off the call. So just take the time to introduce yourself one by one and just share one thing that you would like to learn in the course. And I'm hoping this will be a way for us to get to know one another. I will bring us all back to the room in about 20 minutes. Oh, sorry, Dr. Catherine, I didn't see that you were there. Yes, I will add you to a group. Welcome, Dr. Catherine. Let me just find which room Julia was in. Oh, maybe I won't be able to find it. Okay. Okay, I think I have added people to the rooms. Hopefully, and whoever doesn't get added, I will add you as we go. So you're welcome to join the groups now, and I hope you guys have a fruitful discussion, and we'll all come together again in about 20 minutes. So you're welcome. Hey, Megan, once I close the breakout rooms, is there anything that you think I need to add before we end the session?
Maybe just post the link in the chat for the WhatsApp group and
Oh,
for
yeah.
the Google Drive if you want, just because then sometimes people click it right then and there, and then they don't have
Okay.
to go find it later. So yeah, and then we can wrap up. And it's okay to wrap up a bit early on the first day because
Yeah,
there's less content. So
yeah, sounds good. Thanks.
okay, everyone should be coming back from the breakout rooms now. It looks like they're all closed.
Welcome back, everyone. I hope you had a really fruitful discussion, and I hope that through the time that you were able to share, even though it was just a short amount of time, that you were able to meet some new people. And I hope that through this program, you really will feel that you're not alone in your work that you're doing right now. I hope that we can connect through the course, as well as through some of the resources, such as the WhatsApp group and the calls that we're going to have. I'll just ask that everyone remain on mute as everyone rejoins the main session. I'm just going to share the link to our WhatsApp group on the call. So if you haven't had a chance to join our group, I'll invite you to join the WhatsApp group. I'll be sharing just updates on the chat. It'll be an easy way for us to communicate. And again, if you do have issues with any of the attachments that we've shared or any of the information, please do reach out to us. This is the link for our WhatsApp chat. And again, this is for all the people who have registered for the course. You're welcome to join the group. We do ask that you just refrain from posting anything that's not relevant to the group. But if you have any questions, just put them on there. We do also have the Google Drive that I shared with you earlier. I will be sharing that on the Zoom right now as well. There's 2 Google Drives. On a weekly basis, we'll be sharing our presentations, which I haven't uploaded yet from our presenters, so I will do that. So that will usually be maybe the day after our program. For all the resources that we have access to, free textbooks, etc., you will find on this Google Drive link. So there's 2 Google Drive links that you can use to access the resources from this program. If you have any issues or questions, please do reach out to us. You can reach out to myself or any of the members of faculty or KEPCA directly. We do have a new email address that you can write to if you have any further questions, and that's PC for Palliative Care, Humanitarian Echo @gmail.com. So PC Humanitarian Echo @gmail.com. And I'll be sharing that as well. Oh, perfect. Thanks, Dr. Megan. So again, just a reminder, our classes will be every Tuesday afternoon around this time. We will be recording each session, and I will share the recording link with you so you can follow up with that. We do encourage each one of you to attend the sessions on a regular basis. And hopefully you'll be able to be with us for the following 11 weeks. Thank you so much for joining us today. I think it was a really great session, and we really look forward to sessions in the future. So thanks again, and we will end our class a bit early today, but please do join us again next week. We will be using the same Zoom link and same information to log in. So you can just save that as well. I hope everyone has a really good week, and thanks again for joining the course. It's really great to meet each and every one of you. Bye, everyone.
Thank you very much. Bye, everybody.
Bye.
Thank you. Thank you too. And this was a great helpful.
Thank you.
course.
Thank you, everyone.
Bye bye.
Thank you.
Thank you. Bye bye.
Bye, everyone.
Thank
It's a very
you.
interesting topic, and
Bye-bye.
next week, inshallah, it will be better
Bye-bye.
than this. Bye.
Thank you.
Bye,
Bye.
everyone.
Yes,
Thank you.
Bye, everyone.
Bye.
If any of the faculty just want to stay on the call just for 2
Thank
minutes.
you. Bye.
Thank you.
Thank you. Bye.
Thank you. Bye.
Thank you. Bye.
Thanks, everyone.
Thank you very much.
Bye.
you.
Thank you. Thank you very much.
If any of the faculty are still around and are able to stick on the call just for 2 minutes, that would be perfect.
Okay.
Thanks to all the participants. We'll see you next week.
Thank you. Bye bye.
Bye-bye.